This is a video in clinical medicine from the New England Journal of Medicine.
Ankle fractures are common injuries that may occur at any age. Fractures typically result from a twisting or rotational injury. Prompt reduction of a displaced fracture of the ankle is important to decrease the risk of trauma to the skin and soft tissues surrounding the ankle joint. Definitive management of displaced fracture of the ankle often involves surgical reduction and fixation. This video will focus on the initial management of displaced fracture of the ankle. The primary indication for performing a closed reduction of a displaced ankle fracture is subluxation of the talus from under the tibial plafond. An unreduced ankle fracture that threatens the integrity of the skin can lead to serious complications, including necrosis of the overlying skin and infection. Prompt reduction and splinting of the fracture can prevent such complications and decrease pain, making patients more comfortable as they await definitive treatment. Closed reduction is contraindicated in patients with non-displaced fractures. In such cases, splinting is useful for reducing pain and limiting the possibility of future displacement. Closed reduction is also contraindicated in patients who have not provided informed consent or in patients in whom adequate analgesia cannot be achieved. The ankle forms a mortise joint with the talus fitting snugly into a groove formed by the tibia and the fibula. Ankle stability results from the interplay of the talus, tibia, and fibula, and the medial and lateral ankle ligaments. The ankle joint is medially constrained by the deltoid ligament and laterally constrained by the distal fibula and the lateral ankle ligaments. The most important neurovascular structures around the ankle, including the posterior tibial artery and tibial nerve, run posterior to the medial malleolus. These structures are at risk of damage when there is substantial displacement of the ankle bones. The anterior tibial artery, which lies on the anterior aspect of the ankle, courses distally to become the dorsalis pedis artery. The deep and superficial branches of the peroneal nerve also cross the anterior ankle. The medial and lateral malleoli on the posterior calcaneus are usually palpable, even in a grossly displaced fracture of the ankle or dislocation. These surface landmarks are useful during reduction maneuvers. For splinting, you will need non-sterile water, non-sterile gloves, a non-sterile gown, a cap, a face shield, and splinting material. Lay out the splinting material, which consists of a 10 centimeter plaster U slab with 10 to 12 layers, a 10 or 15 centimeter plaster posterior slab with 10 to 12 layers, and adequate padding such as cotton undercast padding material. The undercast padding material can either be placed onto the splinting material or applied to the patient when the ankle is reduced. You will also need a 10 or 15 centimeter elastic bandage that will be used to wrap the splint. Some clinicians prefer to use non-elastic bandages to reduce the amount of pressure created by the splint. If plaster slab material is unavailable, pre-made fiberglass slabs can be used with non-sterile water. A local hematoma block can be used for anesthesia for ankle reductions. The equipment needed for a hematoma block includes a sterile 10 ml syringe that is pre-filled with sodium chloride and 1% lidocaine, a sterile 22-gauge needle, an antiseptic solution that contains chlorhexidine or povidone iodine, a sterile marker, sterile towels, and a self-adhesive bandage. Explain the procedure and its benefits and risks to the patient and obtain written informed consent. Ask the patient if he or she is allergic to any medications or skin preparation solutions. It is important to take universal precautions during the examination, the administration of the hematoma block, and the performance of the reduction maneuver. All medical personnel present should wear gloves, a gown, a cap, and a face shield. Begin by thoroughly examining the patient. Inspect the skin for any abrasions or tears that might indicate an open fracture. Open fractures require urgent surgical treatment to decrease the risk of infection. Next, assess the neurovascular status of the affected leg. First, evaluate the sensory function of the peroneal, saphenous, sural, and tibial nerves, followed by the skin color and the quality of capillary refill. Palpate the posterior tibial and dorsalis pedis arteries for pulses. Vascular compromise may result from a clinically significant deformity of the ankle. Reduction often improves vascular status. If vascular compromise is still suspected after reduction is performed, an urgent evaluation by a vascular or an orthopedic surgeon is required. To perform a hematoma block, first identify the proper location at which to insert the needle. Locate the space that is bordered laterally by the anterior tibial tendon and medially by the anterior aspect of the medial malleolus. A palpable soft spot is often present. Mark the location with a sterile marker. Then clean the skin with antiseptic solution. Pierce the skin and aim dorsolaterally. If you encounter the bone of the tibia or talus, retract the needle and redirect it into the joint space. Aspirate a small amount of fracture hematoma to confirm the intra-articular location, as most ankle fractures result in an intra-articular hematoma formation. Inject the solution into the fracture hematoma. Dress the puncture site with a self-adhesive bandage. Have your assistant position the patient so that the affected leg is placed at approximately 45 degrees of hip flexion and approximately 45 degrees of knee flexion. This position facilitates reduction by relaxing the pull and deforming force of the gastrocnemius muscle. To perform the reduction maneuver, grasp the calcaneus and hind foot. If the ankle is fully dislocated, you will need to use axial traction to pull the talus into position underneath the tibial plafond. The most common fracture pattern involves lateral subluxation of the talus. The talus and hind foot resume their correct positions once the talus is partially under the tibial plafond. Hold the hind foot firmly in one hand with the butt of your other hand at the level of the tibial plafond. Apply varus and medial force to the hind foot to slide the talus into its correct position. It may help to internally rotate the midfoot as you apply pressure. Once it appears that the reduction has been successful, you can perform Quigley's maneuver to keep the ankle in the reduced position. To perform Quigley's maneuver, simply hold the big toe to maintain the varus and medial moment on the hind foot. This technique is primarily used for fractures that involve either lateral or posterior translation of the talus with regard to the tibia. Once you have reduced the ankle fracture, dip the splinting material in room temperature water and apply the posterior slab of the splint. It should extend from just beneath the popliteal fossa to approximately 3 centimeters beyond the big toe. Wrap the slab with a single layer of cotton padding material to maintain its position. Next, apply the U-slab. Ensure that the slab covers the lateral and medial malleoli. An additional layer of padding is useful to hold the splinting material in position and to prevent the plaster from sticking to the elastic bandage. Wrap these slabs very loosely with an elastic bandage. It is crucial to avoid stretching the elastic bandage as it is applied. Stretching the bandage can cause pain and may even cause compartment syndrome. Once the ankle is encased in the splinting material, gently mold the material to maintain the position. With one hand, apply gentle pressure around the distal calf just proximal to the injury. And with the other hand, cup the hind foot and apply gentle pressure to preserve the position until the plaster material hardens. Be sure to apply an even amount of pressure. Any uneven areas can lead to pressure sores. To avoid the creation of undue pressure points on the underlying skin, apply pressure with the palms of your hands rather than your fingers. Take particular care when treating elderly patients in whom pressure points can lead to major skin ulcerations. Hold the mold in place while the splinting material hardens. This process may take 5 to 10 minutes. Once the reduction is complete, it is important to reassess the neurovascular status of the affected leg. Any neurovascular compromise may lead to severe complications. Instruct the patient to avoid bearing any weight on the affected leg until the injury has been assessed by an orthopedic surgeon. In elderly patients, be aware of friable skin, since traction may lead to large abrasions. The use of hot water or the application of too many layers of plaster can induce clinically significant burns. An incomplete reduction or a loss of reduction can cause skin damage. It is also important to use sufficient padding, especially around the bony prominences, to avoid skin breakdown. Displaced fracture of the ankle is a common injury that can cause clinically significant pain and skin complications. Knowledge of the basic reduction technique is essential to decrease the risk of these complications.